Well, thank you so much, Brian, for inviting me to this round. So in CV ICU, basically we do the same thing, and those are the common indications for critical care ultrasound or echo. We use it for volume assessment a lot. We use it for global ventricular function, for weaning or escalation of inotropes, to differentiate the type of shock when somebody is in shock, assess hypotension sometimes, drop in blood pressure, hemodynamic ventilator interactions, pericardial and pleural effusion assessment, and benefit from drainage. So far it's the same as anywhere else, not much different. Where is the difference? The difference is probably when mechanical support devices are used. So the Avalon cannula position, we use it a lot to ensure that the cannula is in right position for VV ECMO. Clot-causing tamponade would probably be the most common use in CV ICU in somebody who has a physiology of tamponade after cardiac surgery. Usually stop making urine, CVP increases, lactate increases. They usually have been bleeding the night before, and then they clot, and then they tamponade. Echo is cornerstone in trying to find where is the clot, and it's different than the tamponade we see in medicine and general ICU, even in CCU, because it's usually a loculated clot. It's not pericardial effusion. So it's a bit harder to find. The physiology is the same. We're gonna have a case and talk about that in a minute. Response of LV function to change of LVAD flow. So when we have an LVAD, the interaction between the LVAD or the VAD and the left ventricular or right ventricular function is a bit interesting, and it's a good use for echo. Screening for prosthetic valvular problems after surgery. So those are kind of the indication that will be probably done in CV more than other places. But for the most part, we use it for the same reasons that is used anywhere else, in emergency, in ICU, perioperative. So let's start with a case. So it's kind of a bread and butter case in CV. 55-year-old male, post-cabbage, 4 grafts last night, bleeding overnight. Given blood products for coagulopathy, the CM, hypotensive, anuric, and increased lactate CVP, 18. So this is very interactive. Feel free to stop me and to ask or to answer.
Sometimes these guys can bleed overnight and then actually clot in their pericardial space. See?
Absolutely.
Nice.
That's easy. Done.
Nailed it.
I don't know if you knew that.
So Adam knows the diagnosis without echo, so he will probably ask the surgeon to take the patient back to OR because he's clotting and tamponading. However, it's nice to know what's happening, and anybody wants to take this? What window is this? And quick interpretation. Nothing is challenging, I promise. They're all.
So you're saying it's an apical 4-chamber view.
Yeah.
You can just speak a little louder just for that.
Oh, sorry. Yeah. Reduce the FO type.
Right. So would you say mildly reduced, moderately reduced, severely reduced LV function? Moderately reduced, I go with that. I would say it's 35-40%, or 30 to 40%. Okay.
Maybe RA is collapsed.
Right.
Yeah.
Correct. And what's around the RA and the RV?
This is, I don't know.
We don't have laser, do we? I'll use mine. So, yeah, you got it right, man. So what do you think is happening to this guy? Right. From an effusion or a clot or this is the clot, yeah. So that's good. So there is this hyperechoic density here, and that's a clot. Okay. Now I find it very hard to tell if the clot is inside the heart or compressing from outside the heart. The other day we had a guy who had BIVAD, and the clot seemed to be inside the left atrium, which doesn't make any sense to us. He went to surgery and the clot was outside. So really, it's very difficult to tell. The bottom line is that there is a loculated hyperechoic density compressing the right atrium and the basal part of the right ventricle, and it's probably causing tamponade. So, I mean, it's probably most of the time after cardiac surgery, it's extrinsic. It's from outside, right, in the pericardial space compressing, and you can see the right atrium became like a tunnel, right here, very small, and the blood is not flowing through. Go ahead.
I'm going to say, I would suspect that another view would really help confirm this finding. Right?
Absolutely.
You're kind of going on next.
There you go, man. That's your next view. Mohammed, do you want to continue?
Yeah, this is, I would say, subcostal.
Right. Subcostal, yeah.
You can see
This.
Right, yeah.
There is a liver here, and there is something like a liver here too. So what do you think this is?
Collapsing RV.
It's completely collapsed, actually. It's interesting how different windows gives you different impression about the severity of the process. But this is not uncommon, right? We see, and I'll see more examples of that. A pathology that in one window looks much worse than another window. On epical, we didn't have an impression that this is that bad. This one, I will call the surgeon right away. This is right. Like
That's pretty impressive.
this guy is gonna collapse soon, and if arrest. And if he doesn't, if the surgeon doesn't come in, you'll have to open his sternum, which I haven't done yet, and I don't want to do.
You can also see that in where the right atrium kind of should be, or
Right,
is
here.
placed.
Yeah.
Because that's kind of there's this hyperechoic kind of bubbling densities. Which is
Correct.
like a
Those stuff there.
spontaneous echo contrast, right? It's
Correct.
from
Absolutely.
stasis.
Right, from stasis, absolutely. You see spontaneous contrast with low flow, even without injecting anything into the venous system. So it's loculated. So this is the posterior pericardial space. There's nothing. It's all anterior compressing the RV. Now, in tamponade physiology on echo, just like on physical exam, the most important is high JVP, right? Increased filling pressures. On echo, I always tell the residents that if the IVC is not dilated and not collapsing, there is no tamponade. Don't tell me that the RV collapses with diastole. Don't tell me that there is mitral inflow variation with respiration. Don't tell me that there is septal shift with inspiration. I don't care. IVC is not dilated and not collapsing. There is no tamponade. The reason is tamponade is a relationship between the pressure in the pericardial space and the pressure in the RV and RA. So if the RV and RA pressure is very low because the patient is dehydrated, it's easier for that pericardial pressure, even if it's not that high, to compress it. But then the IVC will be small. So until you give 2 liters of fluids and reassess and tell me that now I gave 2 liters fluid, I've increased the RV pressure and the RA pressure enough, and the IVC became full, right? And then still there is a tamponade physiology, then I buy into having tamponade. That's why when you have a tamponade and emerge, the first thing to do is to give fluids. Fluids, and then you can use pressors if you want, but fluids first.
There's definitely we've seen a couple of cases in the last year where there's been a fixation on getting a pericardicentesis at the expense of giving fluid.
Right.
And that's been a huge problem, right? But the morbidity and mortality from waiting.
I have abandoned pericardicentesis multiple times because fluids fixed the problem. Not that we have, maybe we'll do it in 2 days from now, right? But it's not as emergency as it seems to if you give fluids and you fix the hemodynamics. So what is the most important thing to look at is the IVC, because it's your filling pressure. So you tell me that the filling pressure is high now, and he's still hypotensive, so that means he's still tamponading.